I will take you through a brief of why we actually have air on table today. So about 1.8 million babies will die at the time of birth due to birth asphyxia or breathing problems at birth. And these babies really would need help to breathe. I mean, you would help these babies to breathe, and it's something that can be done. But 1 in 5 of the best healthcare workers will actually do the right skill of helping a baby breathe at birth. And there are good programs in place, like the Helping Babies Breathe, the neonatal resuscitation program, which is for the Western world, and they're actually coming down here to train our in-service healthcare providers about how they can actually save babies at birth. But what happened is that for every 30-second delay in helping a baby to breathe, that delay will cause the risk of death to about 16%, which is really big, and we couldn't ignore it. And so we came up with what we call the air device, one that you see attached, that is an add-on to the normally existing resuscitation bags. For those of us that might not be medics, this is what they will use for a baby that can't breathe on their own. And so what we have done is add on to this gadget, this device that we call the air, and it fits in so well. And what the air does, I hope I'm audible enough.
Yeah.
And what the air does is that it fits in well.
Someone should hold this because I just
Okay, thank you. So what the device does is that it gives you feedback, and it's real-time feedback about what would normally go wrong if you were doing your ventilation on your baby. And what it does, the 3 things that normally go wrong is the way you press your mask around the baby's mouth and nose, so as to create a good seal. And if you don't do that, then you will leak the air out. And the other thing is about the patency of the airway. Is your airway clear enough, or is there blockage? And our third icon talks to us about the rate at which we are actually giving these breaths. It shouldn't be so fast, it shouldn't be so slow, so there's a normal range at which you should go at. And so this device has been designed to give you feedback while you do your ventilation. I will do a demo if I were trying to ventilate this mannequin. We expect it has the traffic lights, the reds and the greens. So if you're having the greens, you are doing the right of the job. And if you have red, then that's like a sign like you're not doing so well, you need to improve right here. So if I started to bag this mannequin, all you need to see is a gentle chest rise. And as you can see, that's real fast. So if I start to bag a little faster, we all see that. But if I actually slow down to the 30, 60 breaths per minute, it goes all green. If I actually don't flex my neck enough and cause a blockage, it should tell me. We all can see that. But if I actually flex my head, just tilt the right way, it should be able to tell me that that is the right skill, and I should be able to get that gentle rise of the chest. If I cause a leak, it should be able to tell me that. But if I actually put my mask just right, so that I have a good seal and have a good rise of the chest, I should be able to see that as well. So what we have done with this is that we did a randomized control trial with the device amongst 270 health workers. Some of them were midwives, some of them were nurses, some of them were pediatricians. It was really a mix. And we did it from our partners in Boston, 60 of those participants, and the 210 were from here in Uganda. And what we did, we were actually trying to see, well, is objective feedback really beneficial for somebody trying to learn this skill? And so what we did with our randomized control trial, we put them into 2 arms. Well, you could see from this poster right here, maybe even in your free time. And so what we did, we got 2 arms. People had to resuscitate these mannequins with feedback from the air device. And the other group will actually resuscitate the mannequins with no feedback. And so what we did is that we would let them resuscitate like a normal mannequin, just like these ones. They are normal mannequins, for about 2 minutes and 15 minutes to allow them to familiarize with having the device on the back, which is not the norm that they usually do. And then we would also create mannequin scenarios. Some mannequins we would block their airways. Some mannequins would cause leaks along their airways, and some mannequins were normal. And so in either of the group that had real-time feedback and the group that didn't have real-time feedback, we would ask them to actually tell us what they thought these mannequin conditions were for the 2 minutes that they would have to ventilate each mannequin. So in the arm that actually where we had given them feedback, for 50% of the time, participants were able to actually get this effective ventilation, get it sooner, and 50% of the time maintain it for longer. And up to 70%, they would actually tell the right mannequin conditions and say if it were for a block, because they were blinded to it, they would tell this is a block. And so now we think that this air device in helping babies breathe or in training really does build skill, and it helps to maintain it for longer. And one other thing is that we also did a deployment in about 20 health facilities. 10 in Wakiso were receiving feedback during their practice hours at those practice sites. And then 10 in Mukono had devices. Maybe what I didn't tell you about the device is that it has an SD card onto it. So as you actually ventilate, it records your resuscitation episodes. So the 10 in Mukono had devices but were not receiving feedback. And then 10 in Kampala, we gave them training mannequins and they were actually not having any devices. So among the three arms, we noticed that there was increased peer learning amongst groups that actually had the air devices at their sites. And we were doing it in partnership with Save the Children, and what they used actually, the air device was one of their tools that they would use to actually train health workers to be more conversant and know the right of the skill that they were performing. So that is what we have done now, and what we are thinking is that we are going to scale up use of the air device in about 36 health facilities here in Uganda, 12 in Ghana, and about 4 in India.
Yeah, so just a little background about the app is 500 million people around the world live with disabling hearing loss. And health audiologists say it's very preventable if it can be detected early. But we cannot detect it early because we have very few audiologists per the number of people we have in the population. So according to the World Health Organization in Sub-Saharan Africa, we have one such people as Josephine for every 1 million people. So the importance of this little introduction is to show you from where we are to where we're going. Now the figure on the left here is the standard pure tone audiometry process. If you have any hearing problem, this is what you require to do just one test. You require a PTA machine, which is this machine here, with a computer and all. You require a soundproof room. You can see the audiologist is here and the patient is in here. The pure tone audiometry machine is producing sounds and the patient is responding in the soundproof room. It's costly, it's not easily scalable. So what we've been doing over the past 2 years is translating this entire hardware into a software that can allow someone use their mobile phone to do this entire testing process. And again, because the phone is going to be a very small screen, I just wanted us to see the different screenshots of what the app looks like. That's the welcoming screen, and this is where you go to access the different options the app gives you. So you can choose to do a new test, you can view your results, you can contact a doctor. So if you do this at home, you can use this option to directly message Josephine your results so that she can advise you. And also you can contact us for help. This is the translation we've done. So this is the machine I showed you initially in software. It produces sounds of different loudness, which we call decibels, and different frequencies. And for the left and right ear, the patient responds to see which sounds they can hear and which sounds they cannot hear. In the background, the app is plotting this audiogram. In the initial image I showed you, the audiologist has to plot this manually. So the addition to the app is that it plots this in the background as the patient is taking the test, and it gives you results according to the World Health Organization classification of hearing loss, depending on what average you can hear in the left ear and what average you can hear in the right ear. It's available on Google Play Store. The current version that is available can only be used by audiologists, but we certainly will publish a version that can be used by individual patients. Currently, the app is undergoing clinical testing, so we are going to conduct a study with 120 patients, and possibly next year we will be showing you the results. But now, for the demonstration, Josephine will take us through.
Okay, thank you. So what you need is your phone and then headphones. So you connect that, and I think you saw this page. So you set it to the loudness level, and then the frequency that when we are testing, we test different frequencies. Frequencies, I think you remember in your physics, like how it sounds. Is it a bass? You know, in music, bass is low frequency. Then there are those high frequencies, like a voice of a child or a female voice. So there are different frequencies. So you will go to this, and then you, of course, put your headphones on the person you're testing, and then you instruct them to respond every time they hear the sound. So when you are testing, we want to get the lowest level at which you hear, and that's how good your hearing is. In audiology, that's how it is. So, for example, if you look at this screen, I have 60, that is the loudness. So this is the frequency, it's 1,000 hertz. So I will instruct the person to respond by maybe raising up their hand when they hear the sound by pressing this. And then they will respond. And then I will say whether they have heard. If they have heard, I press that. Okay? If they have not responded, then I'll press. I don't press anything. So it will record. The machine records whether there was a response or not. And then I'll test right ear and left ear. So that's what we do, and then we will get the results. So it's simple. It's better to experience it. If you want to try it, I will put headphones on you, and then you respond.
And we are in ICT solutions for health providers. So essentially what we do is we identify challenges within the health sector and come up with ICT solutions to solve those challenges. Chief among the projects that we have done in Zimbabwe include a telemedicine pilot, which is running in 2 districts in the eastern province of Manicaland. We're involved in research. We are also involved in learning management systems. And we have also developed a number of mobile applications. One is a pharmacy manager, a malaria community care application, and also a bad-ness application. So the malaria community care application really is to differentiate between severe and non-severe malaria, and the bad-ness application is really to prepare nursing students with their clinical placements when they're in hospital. But coming to the application, which I will demonstrate shortly, it's an application to deal with the challenge of providing education. In Zimbabwe, it is a requirement that healthcare workers annually are engaged in continuous professional development, and they actually have to provide evidence for having undertaken those activities. And some of these health workers work in very remote communities where there's minimal supervision and there's limited access, and there's also inadequate clinical support between these healthcare workers. And we have about 35,000 of those healthcare workers in Zimbabwe, and we know that CPD is actually a very key intervention which can enable skills update and provision of education. So whilst we acknowledge that, we know the traditional CPD programs that are already going on, they have some challenges which have already been identified, and this is cast across many African countries. And some of those challenges are to do with infrastructure, to do with financing for the CPD programs, poor attitudes, low morale in the workplace, personal commitments, and also CPD relevance, where healthcare workers get CPD which doesn't tally with the needs that they actually identify. So when we came up with this solution, we wanted to address one, access to CPD, and at the same time deal with these challenges which have already been noted. So this is just a snapshot of the solution, where you find that there's a module for a library, a module for professional courses, for an essential drugs list, and also another module for clinical tools. I will show some of those things. So that's the landing page in terms of, that's the landing page for the mobile application. And the screens that you see on your right, sorry, on your left, which is on your left, you see the CPD activities, professional courses, the ADLIS clinical tools. And then on the other side, there is a list of CPD activities which will be available. Those CPD activities will be profession specific. So if you register as a nurse, you get content which is specific for nurses. If you register as a doctor, you get content which is specific for doctors. Once you click a CPD activity, you then get the activity detail, where there is the overview, the start date and the end date, and the points which are weighted by your CPD provider. So we are essentially just a platform provider. The CPD provider then brings their content, and it is weighted already. So there is start date and the end date. It's to ensure that healthcare workers are able to be learning on a continuous basis. You don't get a health worker coming at the end of maybe the CPD cycle, then does all the activities, get their points. They are not learning on a continuous basis. So there is a start date, end date to ensure that the activity is pulled down when the end date is reached. In terms of assessment tools, there is a pre-test and a post-test, and you have to clear the post-test for you to be able to earn the weighted points. Other things that we've then integrated with this application are the clinical disease support tools. You know, we always have PDFs and hard copy, of malaria guidelines, HIV guidelines, etc. And the health workers have to flip through the pages to be able to access these. We have now digitized these tools so that they are available on the mobile application. And currently there's the malaria guideline, the TB management guideline. And if you click on a tool, you are able to then access the content within that guideline. Another tool which we have done, which is something that is quite familiar in other African countries, is that each country is an essential drug list of medicines. And this again comes in the hard copy format or the PDF format. What we have now done is that it's now searchable on the mobile application. You get the list of medicines A to Z. When you click on a medicine, you get the conditions in which it is used, the adverse effects, the drug interaction, and this can aid a clinical worker when they are actually prescribing medications. Other things that we have done is emergency guidelines, and these can be used in the acute setting when someone is treating an emergency. You can refer to the definition, the diagnosis, and also steps to actually manage that condition. We have also incorporated other emerging technologies like a QR scanner, whereby if you come in and attend conferences, you can be able to access the QR scanning functionality on the mobile application, and then it records your meeting attendance, and then it also gives you the points for that. And then there's a points tracker, which tells you how many points you need to get specific for your profession and how much you have done. So that's a healthcare worker scanning a QR code to be able to earn their meeting attendance. So as a way of concluding, some of the lessons that we have already learned in terms of implementing this solution in Zimbabwe, we have just concluded the pilot phase and the testing, and the solution will be launched in the middle of April, 16 April in Zimbabwe by the Ministry of Health, because we are partnering the Ministry of Health and Childcare in Zimbabwe. It's now live on the web Play Store, App Store, and what we've done is we've integrated CPD and clinical disease support tools. Normally you get applications where maybe you just get the clinical disease support tools, the guidelines on their own without the CPD component. But we have demonstrated that integration is actually possible. In terms of sustainability, training is key of the healthcare workers so that they understand what this is all about. Partnerships are key with CPD providers, accredited CPD providers. Like in Zimbabwe for nurses, we are working with the Zimbabwe Confederation of Midwives, which is the biggest body for nurses. And then you know that content will come in through that. In terms of potential for this application, we believe it is huge. It allows standardization of CPD and sharing of CPD across professions. Sometimes nurses have stuff that they want to share with doctors. Sometimes doctors have stuff that they want to share with pharmacists. With a mobile application, that becomes all feasible. Participation of nurses in the private sector, in the diaspora, that is also very possible because it's a mobile application. And then cost savings in terms of time and in terms of even finances for healthcare workers. So those are some of the issues that we have already begun to see as we deploy this application. I thank you. So I was demonstrating that's the landing page in terms of the screen. So if I go on to CPD activities, I then get, I should get a list of CPD activities relevant for my profession. I can be able to choose. These CPD activities can be in PowerPoint, they can be in video format, they can be in journal articles, it's all possible. So then the essential drug list of medicines, there are two modules, a drug and a conditions module. If I click on the drug module, I get the list of medicines which are available, and I can be able to choose the medicine that I'm looking for. If I click acetazolamide, I get the condition which is used, the drug interactions, and also the adverse effects. And also for all these clinical and support tools, they are also available in offline mode. So once you have downloaded the application, you can always, even without network, you can always be able to refer to them. So protocols, I showed that. Clinical tools, those are the guidelines that I was talking about, malaria guideline, TB guideline. And then in terms of some of the administrative features, you can check your account. My CPD TV, that's a live streaming functionality which allows the healthcare workers to be able to remotely participate in certain sessions which will be being live streamed. Like the session that we are having now, you can actually be able to set it up and the healthcare worker can be able to follow remotely. The library, there are videos to demonstrate things like helping babies breathe, basic life support, etc. And then the QR scanner, like I said, once you have your QR code, you can be able to actually scan this and then you earn your meeting attendances. I think it's available on the Play Store, App Store, but it's just specific for Zimbabwe. So if you want to take a look at it, you can be able to take a look and see the features. But soon I think we'll also have Uganda on there. Thank you.
Very much. My name is Dr. Stella Ello. I'm the program manager for the East Central and Southern Africa College of Physicians. So I know that's relatively new to some of us, and I'm just going to give us a brief background of what ExaCop is. So we know that Africa bears almost a quarter of the world's burden of disease, armed with only 1% of the global resources to deal with that burden, and a mere 1.7% of the entire doctor or health worker population. And when we take a closer look at sub-Saharan Africa, looking at the figures, we see that most of the countries have only one physician for a population of 10,000. And what that means is that if 10,000 of us fell sick, we'd have to wait in line for a very long time to see a physician. And bringing it closer to the countries that are member states, Kenya, Uganda, Tanzania, Zambia, Zimbabwe, Malawi, these are the countries that make up ExaCop. We see that the number of physicians in these countries is very inadequate, and what is even more disheartening is the annual output. So currently there are a number or a limited number of training institutions, mainly universities, that offer specialist training in internal medicine. And for Uganda at the time, that was 2 years ago, we were only producing 18 physicians a year. Some, not all of them are at clinics right now. Some of them are deputy heads of academies, and others are standing before you giving a presentation. So even with the figures that you have, not everyone is currently seeing a patient. Let's bring it closer to home and just focus on Uganda. So Uganda has approximately 200 registered physicians for an estimated ever-growing population of more than 41 million. And the medical schools, which are mainly in the metropolitan areas, that is the cities, graduate about 25 physicians a year. And sometimes that's even less. And on current trends, it will take us 200 years to reach a minimum desired number of at least 5 physicians per 100,000. It's important that we think of urgent approaches to these current problems of very low output, very low numbers of physicians, and most importantly, the urban-rural disparity in physician distribution. So, and this is where ExaCop comes in. So we know that most times when you want to pursue your specialist medical training, you will either move to Makerere or Mbarara or to any of the other institutions that are offering postgraduate training. But most of the time, you've already spent like 10 years at a good facility in Uganda, let's say like Lacho. And honestly, in those 10 years, if you've stayed 10 years in the internal medicine ward, by the time you come out, you're almost at par with someone who has spent 3 years in Makerere University pursuing a career in internal medicine. Trust me, when you decide to make the move from Lacho to Kampala to pursue your master's in internal medicine, chances are you are not going to go back. And as a result of that, the rural population you've left behind is going to suffer. So that's one of the things that we thought through. What model is going to be applicable to solve this problem? And here comes EXACOP. EXACOP is one of the constituent colleges of the EXA College of Sciences. EXA stands for East Central and Southern Africa Community. The physicians have their own college, EXACOP. The nurses have their own college, EXACON. The pathologists, the surgeons as well, and many of these have preceded us, okay? And our aim is to improve access to well-trained physicians by training physicians at sites, mainly sites serving the rural population, so that they don't have to make the move to the cities. And so we have a clearly defined mission and vision, and like I've already said, physician training has been going on in Africa way before EXACOP came in, following the same model. So in West Africa, you already had the West African College of Physicians. In South Africa, there's the South African College of Physicians. The Arab countries merge together with their neighbors and train under the Arab Board of Health Sciences, and the last born in the vicinity is EXACOP, which is currently barely 3-4 years old. And so a virtual college was born. And so what is happening is that we have identified training centers. Currently, the pilot sites are in Zambia and Zimbabwe. In Zimbabwe, training is going on in Harare Central Hospital and Pilo Hospital in Bulawayo, which is familiar with, and 3 different sites in Zambia. So the question comes, you are a single award-giving body. How do you ensure that your trainees have as uniform a training experience as possible? The same way as if you had your ACCA qualification, for example, how do you ensure that the people you are awarding, because they're in different countries, are all standardized in terms of the access to resources and the like? How do you ensure that there is progress being made? How do you monitor the assessments? How do you create for them a platform through which they can actually assess themselves and also track their own progress? And that gave birth to the EXACOP virtual learning environment. So the EXACOP virtual learning environment, which is the focus of my presentation today, was a software system that was designed to facilitate the management of training. And what it enables us to do is to deliver a wide range of learning material in different formats. So it is designed to deliver not just material in written format, but also make provision for webinars and live conferencing as well, to be able to track learners' progress, to empower learners to track their own progress, and to create a trainee support and a trainer support so that they feel like they're part of a single community. So like I said, currently, the trainees are scattered in Zambia and Zimbabwe. This year, we're going to have the 2 next countries in line, Uganda and Malawi, joining the training cohort. So it's important that you ensure that there's at least a community of practice so that people don't feel so isolated. And that's what the virtual learning environment does. So this is the EXACOP website, and at the top right corner, there is a link that's labeled the School of Internal Medicine. This is a private space that only trainees and trainers can access. So this is what the login page looks like. You enter your credentials, and as a trainee, whether you're in Zambia or Zimbabwe, this is the page you're going to find. So I will only concentrate on the content that's behind the courses, the Knowledge Hub, and the e-portfolio, because the notice board and the discussion forums are relatively self-explanatory. So this is what a dummy account looks like for a trainee. So as you can see, as this trainee is currently enrolled for a course, the electrocardiogram course, they are also able to navigate back and see the courses they've completed. They can check and see what are upcoming courses, and also look at the key training documents. The other feature is the Knowledge Hub. The Knowledge Hub is like your digital library, accessible again across borders. And this is a snapshot of what the page looks like, but they're segmented under ebooks, e-journals, e-resources, open access resources, journal club articles, and case reports. So very similar to what my colleague has presented beforehand. The last thing that I want to concentrate on is the logbook. So as a trainee after 4 years, you will have to provide evidence that you have engaged in learning activities. And whether you're a surgeon or a physician or a pediatrician, there has to be proof of a certain minimum of activities that you have to engage in, and that has to be recorded. So traditionally, when you go to the medical schools, in your first year, you're given a hard copy logbook, and you're told every time you make a presentation, every time you admit a patient, every time you do a procedure, you have to record that in a hard copy logbook. And we know what happens to those logbooks. Sometimes your room floods, or sometimes actually, when the going gets really tough, people come up with different stories to explain why the logbook is emptier than what it should look like. This is an e-portfolio that has attempted to solve that. So you have your procedures. So there are minimum number of procedures you're supposed to do before you attain a certain level of competency. You need to record that each time you do a procedure. The same thing for admissions, the same thing when you're doing calls, the same thing for the CPD activities. I'm cognizant that time is not on my side. And so going forward, we envision that this virtual learning platform is going to have to grow to become a CPD tool, not just for trainees, because once they get out of training, they will now be professionals. And like we already, I already mentioned earlier, that is the task that was ahead, and my colleague has already made it so simple for me. So thank you for listening. And
so my name is Dawi Kasa. I'm country director for Zenesis Ethiopia. Zenesis is a data that specializes in advanced and rapid data interoperability and data analytics. So that's what we're going to talk about today. I'm going to give you a quick overview of what we do and give you a live demo as well. So data interoperability is really ability of systems to bring and join up their data and without losing a meaning. And it's really important for various organizations for a number of reasons. First of all, we know that from data science, by bringing data from different sources, you can actually identify powerful insights that could transform the performance of your health sector. And increasingly, stakeholders, including donors, push decision makers in the health sector to make evidence-based policies and decisions. But the hard reality for a number of companies is that their data is siloed and kept in different places. These systems don't really talk to one another, and there has to be a way to bring that data all together. Technical reasons, for instance, that lead to issues with interoperability include, for example, different silos systems don't really agree on the number of facilities or districts that you have in a country. And in Ethiopia, where I come from, some data sets use the Ethiopian calendar, which is 7 years behind and has 30 months in a year. And also, there are differences in naming conventions, and some data systems, if you look at the numbers, some do record events per year, for instance, where others do kind of cumulative aggregates. So these are all things that have to be sorted to make your systems interoperable, and that's where you need a platform like ours that automatically can do the integration. So what this platform really does is it doesn't really replace your systems, it doesn't really modify them, but instead it just really sits as a unifying layer on top of everything and really gives you overview, global view of your data. So our company was established in 2015, and since 2016 we've been working in Ethiopia, and currently we are operating in 8 countries, including Rwanda, South Africa, Togo, Liberia, Zambia, and recently in Pakistan and India. In the case of Ethiopia, we've managed to integrate about 15 data sets with a total of nearly 1 billion data points. So it's really powerful platform. So with that, I'm going to go straight into the demo. So this is a platform. This is platform from Brazil. It has 5 data sets into it. It has completely different databases, which we have managed to harmonize. They contain about 65 million data sets. And what I'm going to do is go in here. So this is a query builder, and I'm going to look for pneumonia, and I have pneumonia indicators in 4 different data sets. The first one is about number of pneumonia vaccines distributed to different parts of the Brazil. And the second one is number of people admitted to hospitals, and the third deaths, and finally the dollar amount of money that's spent to treat pneumonia in different hospitals. So what you see here is so what you see here is all those data sets shown side by side. I can do many kinds of things with this, but in this case, what I will do is go immediately in here and create a new indicator by combining two different data from different sets. Okay, and I have it right there, and what I will do in this case is I will just decide to exclude some of the data. So imagine how this will be done if we have to do it manually. And then I'm going to put this mortality rate on separate y-axis, and then do some more trick, and I will tell you what this does. And with that, I can see which parts of the country, in this case municipalities in Sao Paulo, have the highest mortality rate, but still get the relatively higher amount of vaccinations. And I can also quickly expand the data to see just any data anomalies in the data that I have. I can also do the exact opposite, which is to look at number of or the districts that actually have very low mortality rate but still get quite a lot of vaccinations. So just some of the things that you can do. I can look at this data in various ways. I can do time analysis. This usually depends on the speed of the internet. So this is a preloaded version of it. I can look at this also in a map. Screen is a little bit funny. Oh, this is not working out. But the point is, there are really many ways that you can look at the data. And once you're done with analysis, you can actually save your data to a dashboard. A dashboard is similar to a PowerPoint that you can come back to later or share with other people. This is the dashboard that we built for the Ethiopian government. It has a number of dashboards, as you can see, where people can come in and interact by filtering on geography and the year. So these are all things that can be done. And recently we've made available a new query tool, just similar to the one that I used in the beginning, but this is really more advanced in that it's really user friendly, very has logical flow, and can do some advanced calculations like medians, average, and a few other things as well. So in addition to all the things that we've seen, the platform can do forecasting. It uses some machine learning to look at historical data and really give you some pretty accurate single-digit forecasts. It can also do alerts. That's really to set up notifications for indicators whose thresholds are exceeded. That is really briefly about the technology and really looking at the impact. For instance, this solution was used in Ethiopia, and the government was able to save about $30 million in their vaccine campaign on measles. And we also used it to allocate about $125 million in a very targeted way, again, in Ethiopia. So in summary, just really what the solution really ends up to is just really bring your data all together and do all kinds of really interesting analysis and really give you that global view of your data.
I'm called William Waswa from Malaria University of Science and Technology. I'm a PhD candidate in biomedical engineering, and this has been my research, which we have actually finalized, and it's a digital pathology platform for automated diagnosis and classification of cervical cancer from pap smear images. So some little bit of background. Globally, cervical cancer ranks as the fourth most prevalent type of cancer worldwide, with over 500 cases were reported in 2018. That's according to the World Health Organization report, representing 6.6% of all the types of cancers among females. And from this report, it was noted that all the highest incidences were actually occurring in low-developed countries, specifically in Africa. And over 80% of these cases were actually detected in their late stages. And in Uganda, Uganda is ranked 14th among the countries with the highest incidences of cervical cancer worldwide and 7th in Africa. And in Uganda, it's noted that over 80% of those diagnosed with cervical cancer end up dying because it's always diagnosed at a late stage. However, where is the challenge, or what's the problem that we're trying to investigate? Pap smears or cervical cancer can be prevented through a regular pap smear, through a regular screening application program, and pap smear is the commonest method used for cervical cancer screening. However, the analysis of these pap smears is always time-consuming, laborious, and error-prone because an expert has to really analyze these pap smears under a microscope. This is very, very time-consuming, and it's also monotonous as somebody has to do the same task again and again. Furthermore, the digital microscopes that are available on the market are very expensive, and they have had limited impact in low-middle-income countries. As a result, they are low-cost microscopes that are usually used in cervical cancer screening units. However, these are manually controlled by inexperienced cytotechnician or cytopathologist, who are also very, very few. And they have limited capability of storing these images because the pap smear has to be put on a microscope and analyzed from there and then. Also, risk factor analysis is not fully or sufficiently incorporated into the screening because you can predict the likelihood of somebody having cervical cancer based on the risk factor analysis. Hence, there is a need to come up with a digital pathology platform for automated diagnosis and classification of cervical cancer from pap smears. And what you have developed is what you call a DigPath, which is in three-fold. So you have developed a low-cost microscope. This is the microscope we have developed with 80% of the parts 3D printed from Bio University, which you can use to acquire high-quality digital pap smear images and share them with other cytotechnologists who are off the site. And you have also come up with a tool that you can use to automatically analyze these pap smear images that you have got using our microscope, so that there is no need of a cytotechnician to sit and look at these slides under a microscope. Also, our tool takes into risk factors evaluation. That is based on somebody's age. How many kids does this person have? At what time did this kid start having sex? Does this person have HIV? Because these are all risk factors for cervical cancer. So our tool can compute the likelihood of somebody having cervical cancer given the risk factors. So that's basically the low-cost microscope scanner can produce quick, reliable, and high-resolution pap smear images, and most of the parts have been 3D printed because it can be replicated. And you have used cheaper available electronics, like we are using stepper motors to drive the stage, because focusing currently the manual microscopes, an expert has to focus the microscope to be able to get the good smear images. But with our tool, you can do auto-focusing using the software that we have developed in C++. For cervical cancer risk factors, it assesses the possibility of contracting cervical cancer given the risk factors analysis, and we have implemented it using fuzzy logic based on the knowledge base that was provided by experts. For the pap smear analysis, we are using classical image analysis techniques to come up with a classification algorithm. For the pap smear, we are using fuzzy Siemens algorithm, and we have evaluated our tool using Frank-Back medical system evaluation criteria. That's we are looking at the technical efficacy, diagnostic efficacy and diagnostic thinking efficacy of our tool. And some of the results we have tried to do for technical efficacy, how good can our tool extract features from an image? Because when they are doing the manual analysis of the pap smears, an experienced cytopathologist looks at the slide and looks at the features of the images, because these determine if the cell is cancerous or not cancerous. So they extract like area of the nucleus, area of the cytoplasm brightness, nucleus cytoplasm ratio. So we have tried to extract these features using our tool, and also extract features on given pap smears using an expert, and there was an agreement or correlation between the results. We have done this on both normal cells and abnormal cells. We have used this to do segmentation using existing commercial tools that can be used for segmentation, like CHAMP. CHAMP is one of the tools that is used for segmentation, but it's very, very expensive. So I've tried to get single cell images and also full slide images and try to do segmentation using CHAMP and also compare our results with PAD. So for accuracy efficacy, we have tried to see how can this tool classify a cervical cell as cancerous or non-cancerous, and we have done this on 3 different types of data sets that we have used. We have used some open data sets that are available online to validate our algorithms. Used it on single cells, also full slide cells, also on 60 slides from the pathology unit, but we are still carrying out more tests and expanding on the knowledge base from Barrow General Referral Hospital. And the tool was able to give us a sensitivity of 100% on the 60 pap smears that we have used. That is, out of the 60 slides that we had, 30 were normal and 30 were abnormal. But the tool was able to identify the 30 abnormal cells as abnormal. But for the normal cells, there are some that were classified as abnormal. So it still has a higher false positive rate, which we are still working on to improve. And for diagnostic thinking efficacy, we are looking at how can our tool be in agreement with an experienced cytopathologist on evaluating the risks of a patient given the risk factors. We have so far evaluated this on 8 cases, and on all these 8 cases, there has been 100% correlation between the expert system and expert judgment on these patient cases from an expert. That is, if you give a doctor this information, a gynecologist, and say, this is this patient, maybe he's 80 years, he has 8 kids, the cervical lesion is of this type, he has this number of kids, they can give the probability that this person can have cervical cancer before even to do the pap smear analysis. And currently they do it manually, somebody has to look at this, but if you have over 7 parameters, it's not very easy to give a judgment. But our tool can give an expert judgment or guidance on that. Lastly, for the discussion, for the low-cost microscope scanner, we are able to get high, quick, reliable, and high-resolution pap smear images, which you can get in a very quick time, because when you are getting the pap smears, you scan the full slide. So the manual process of actually getting the pap smear is long, because somebody has to move the microscope until we get the full smear, and it can take 10 minutes, but you are able to get this in less than 6 minutes. The image quality is comparable with high quality, with high expensive commercial systems, because we have compared the image quality obtained using Olipans and our microscope, and at least the quality is good, and it's also very, very cheap. I just didn't carry it, but the microscope is very cheap. All the parts have been 3D printed, and we are looking at the cost that can be at around 150 USD compared to over 1,800 USD for most of the microscopes that are used in the screening centers. For the cervical risk factors, there is really high result correlation between them. Results. Still for pap smear analysis, the features extracted, the analysis, there's great correlation between the different. Finally, future plans, what we are trying to do next is to scan more than 1 pap smear at a time, because currently the stage is small, so you put 1 pap smear, but we are planning to extend the stage so that you can even put 5 pap smears at once and scan them at once. Also real-time pap smear analysis, because currently use the microscope to get the image, then we feed the image into the tool, but you want that as the microscope is scanning the image, it's feeding it directly into the analysis tool. And also we are including fluorescence so that you can use the same microscope for malaria, for other types of diagnostics. And also we are trying to increase the knowledge base for cervical cancer risk factors and assessment. And also based on the different presentations I've done with our research, because we are using a lot of classical methods, but they are telling we can try to use deep learning or deep learning approaches so that it becomes more faster. However, the issue with deep learning is about the implementation environment, because we are working with Mbarara Regional Referral Hospitals and wanted a tool that can really be deployed on any type of computer without needing to have high resource computers. And also we are working on integrating or coming up with an integrated artificial intelligence support cervical cancer patients information management system with this, so that if you have a cervical cancer screening center in Mbarara, in Kampala, in Mbare, all these can be coordinated, and if there is a challenge, somebody from Mbarara can put a slide on this platform, or perhaps an image on this platform, and somebody from another center can also be able to view this. So that's more of telemedicine support using this tool.